joining after the lunch break. So as I mentioned, I'm Dilshad Tung, and I am going to be chairing this session today. We will have two presentations. These are from track 2, which is the non-communicable diseases and infectious diseases track of the conference. And I just wanted to firstly go over some housekeeping items. We will have a evaluation for you to complete that you will be able to see at the end of the session. We will also have CPD information and how to get those points if you registered for them on the conference website, so you can reference that if you need, if that applies to you. And I'm just going to introduce our presenters. First, we will have Dr. Teresia Ambrose Otaru. And Dr. Otaru is a medical doctor and an epidemiologist with a master's in epidemiology from the University of Antwerp, Belgium. She is a member of the academic staff at the Department of Epidemiology and Biostatistics at MUHAS, Tanzania, and a PhD candidate in the NIH grant that aims to build capacity for patient-centered outcomes research to improve the quality and impact of HIV care in Tanzania. Teresia has over 5 years of experience in research design and conduct, data synthesis, and dissemination. Her research interest lies in exploring opportunities to improve multi-morbid care for people living with HIV. Using her experience from previous activities, she is now leading a research project that aims to explore cardiovascular health and provision of cardiovascular-related care for persons living with HIV in Tanzania. The overall goal of the project is to provide recommendations on the design of effective and successful integrated care for persons living with HIV. All right, and with that, I would like to turn things over to Dr. Otaru and just remind anyone in the room that's joining that you can share any questions that you may have for Dr. Otaru in the Q&A box, and she'll have 5 minutes after the presentation to answer those questions. So over to you, Dr. Otaru. Oh, if you're speaking, Dr. Otaru, you're muted. Oh, go ahead. There you are.
Thank you for the introduction, and I hope you can hear me well. As I was introduced, my name is Teresia Otaru, and I'm an epidemiologist and a medical doctor working as a faculty member at Muhimbili University of Health and Allied Sciences in Tanzania. And I'm also a PhD candidate in a D43 grant that aims to build capacity for patient-centered outcomes among people living with HIV. And for today's presentation, I'm going to talk about one of the work that we are working on that looked on the experience of care for hypertension and diabetes among others living with HIV in Tanzania. And we are working together with other colleagues from Northwestern University, National Institute of Medical Research here in Tanzania, and some other institutions, as listed on the slide. So as we know, we have cardiovascular diseases, which are the leading cause of death. And then among people living with HIV, they have a higher burden compared to the general population. And research has shown that this is because of the chronic inflammation that is caused by the HIV infection itself, but also because of the long-term use of the ARTs. And also the cardiovascular disease risk factors are very common among adults living with HIV. In our own work, which was recently published, we saw that significant proportion of adults living with HIV are hypertensive, diabetic, and also have other cardiovascular disease risk factors. So because of this, understanding this burden, the National Guideline for Management of HIV and AIDS here in Tanzania advocates for holistic approach in managing the aging population of adults living with HIV. And here they advocate for screening of cardiovascular disease risk factors. They advocate for provision of health education. And for individuals who are found at risk for cardiovascular diseases, the guideline recommends that the provider should provide treatment. If they cannot provide treatment, then they should provide a referral to a center where they can be treated. But as we know, the health system is overwhelmed, the HIV clinics as well, and they lack resources to implement such recommendations. So our project overall, it wanted to look at what could be the barriers and do we have any opportunities for integration of cardiovascular disease services at the HIV clinic here in Tanzania. So this study had this big project had 3 different aims. And the first aim was to determine the burden or the cardiovascular health of adults living with HIV in Tanzania. And then the second aim wanted to look at their lived experience. How do they access care? How do they ensure that they are adhering to treatment? And how do they think of their health status as patients with multiple conditions? And then the third aim wanted to involve stakeholders and in the health system, including providers, and to understand the barriers and facilitators to implementation of the integrated care. So for this presentation, I'm going to focus on the results of the second aim, specifically on the experiences with care for cardiovascular disease risk factors among adults living with HIV. And here we recruited 33 adults living with HIV with a confirmed diagnosis of hypertension and diabetes. And then they were recruited from AIM 1, which was the biggest study which wanted to understand the overall burden. And then the inclusion criteria was that they were supposed to have had sought care for hypertension or diabetes at least once before the beginning of the study. So we had in total 33 adults living with HIV, and majority were hypertensive, which is the most common risk factor for cardiovascular diseases. And then the majority have lived with this condition for quite some time, more than 5 years. And then we had a relatively old population. The median age was 56 years. So at the end of the day, we had 4 dominant themes, and then within the dominant themes we had several sub-themes. So the first theme looked at the availability of cardiovascular disease-related services, and here we focused at the HIV clinic. And we found that people are being screened for blood pressure, so they have their blood pressure tested, but they don't have their blood sugar levels tested. It's not done routinely at the HIV clinic. And then they're given health education, but it only focuses on how to manage the HIV infection that they have. So they have a very clear understanding of how to adhere to treatment for ARVs, for HIV, and then what are the complications if we don't adhere to treatment. But on the other side, they don't have knowledge on the complications of poor adherence to, for example, hypertension medication. And then even when they screen a person and they find that this person has a raised blood pressure, they do not have the capacity to provide treatment, and then they don't even provide a referral service to a center where they can where the patient can receive that service. And then because of poor availability of these services at the HIV clinic, where it's a place where they routinely go, they face several challenges. And we found that the biggest challenge was that they fail to maintain themselves in care and in treatment, so they lack care and treatment continuity. And this was in larger percent because of the high cost of care and transport. And because of the high cost of care, they developed coping strategies to cope with their conditions. First, they became self-aware of the symptoms for raised blood pressure as well as raised blood sugar. And then when they think that they have symptoms of raised blood pressure or raised blood sugar, they rely on pharmacies and private dispensaries. They avoid government facilities because of time. And most of the government facilities are overwhelmed. So they rely on pharmacies. They just go if a pharmacy can check their blood sugar or blood pressure, they check, and that's when they buy the medication. If they find that their blood pressure is normal, then they don't buy the medication. But even if they find that the blood pressure is high and they only buy medication for a specific period of time, very short period of time, let's say 1 week, 2 weeks, and that's all. And then when the symptoms disappear, they stop taking the medication. And then because of the high cost of care and transport, some have focused on, or they prefer to do lifestyle modification. And unfortunately, a significant number of the participants reported to rely on traditional and herbal treatment. We, on the other side, asked them, if we integrate cardiovascular disease services at the HIV clinic, what is your perception on that? Most of them agreed that it's going to be convenient, it's going to reduce the cost of transport and time. That is, you go to the HIV clinic and then you receive all the services there. They think that it will promote early detection and linkage to care for both hypertension and diabetes. And then they're already familiar with their providers, so they have confidence in their providers. But they were concerned on the structural barriers at the HIV clinic. As I said before, that the HIV clinic is also a facility that is already overwhelmed even in Tanzania. So here are examples of the quotes that we got from our analysis. And we have, I'm going to just mention a few for the interest of time. We have a 42 years old diabetic female who receives health education at the HIV clinic that focuses on the HIV infection that she has. She's told to eat plenty of fruits, variety of fruits, and she can eat fruits anytime she wants. But on the other side, she's also diabetic. And when she goes to the diabetic clinic, she's told not to eat and to reduce the amount of fruits that she takes, and she should be keen on the type of fruits that she uses. So this was a dilemma for her, and she wishes that probably if possible, she could receive a tailored health education at the HIV clinic that focuses on the multiple conditions that she has. We also have a 60-year-old female who is hypertensive and diabetic, who reported to receive a delayed diagnosis. Whenever he went to the hospital, he was just given a drip and a shot of diclofenac, and then he got better. But then he collapsed, and then that's when he was tested and found out that he was diabetic. But if we had routine diagnosis of diabetes, for example, at the HIV clinic, probably this would not have happened to this individual. And then, with regards to lack of care and treatment continuity, we had a 49 years old diabetic male who expressed that he could not maintain himself on treatment, and then he one day collapsed because he ran out of diabetic medication. So here we have examples of different coping strategies. For example, reliance on pharmacies. We have a 58 years old female who say that, why should I be on treatment? I know my symptoms and I don't like taking medicine. So I normally go to a dispensary and then check for my blood sugar and then buy medicines at the pharmacy if I need to. So she is not a regular attendee of any healthcare facility for the hypertension for the hypertension that she has. So some have focused on lifestyle modification and traditional and herbal treatment. And here I would like to give an example of 75 years old male who is hypertensive, who decided to focus on herbal treatment because of because of the cost of medication. And we have other participants who use the traditional medicine, but at the end of the day, they develop complications because of the use of less effective medication or ineffective medication. And then some participants expressed their concerns on the structural barriers, overcrowding, overwhelming the service providers, and then they will be unable to provide the services that are required. So From our findings, we see that there's a significant gap in provision of services. We have participants who reported to not being screened for diabetes, and then they're not given tailored health education. They're not given referrals, nor are they treated at the HIV clinic. And we see the HIV clinic as a potential space for providing cardiovascular disease care, given that we have an aging population of adults living with HIV. But then, even if we introduce those services there, who is going to cover for the cost of medication? That would be the biggest challenge. If they cannot buy the medication now, even if you integrate care, will they still be able to buy the medication? And if the government cannot provide such medications, what will happen? And then we also have existing structural barriers at the HIV clinic. How are we going to handle that? There's also an opportunity to train community pharmacies to provide health education on cardiovascular disease complications and advocate for adherence to medication. So the other question will be, can we utilize the community pharmacies which the participants reported to trust and go oftenly compared to the health facility? Can we use such pharmacies to provide health education, at least on cardiovascular disease complications and importance of adherence to medication? So in conclusion, we see that there is an urgent need to improve care for adults living with HIV, to improve care for cardiovascular diseases, and this can be done at the HIV clinic. But this needs strategies, multifaceted strategies, and then they should be attentive to the existing structural barriers. We could do further research to explore the implementation barriers from the perspective of providers and key stakeholders engaged in policy making, and this is our next step. And then we want to collect all that information and see if we can design a low-cost cardiovascular disease prevention strategy or approach. And then at the end, we should be able to evaluate if the strategy that we have employed has worked. So we propose low-cost cardiovascular disease prevention strategies, such as integration of proper cardiovascular disease risk factor screening, but this will require purchase of utilities, so this probably is more expensive. But provision of tailored health education will require just training of healthcare providers, and then provision of formal referral services. Also, this will require just training and advocation, and that's all. Probably the last two will be the most effective ones in terms of cost. So with this, I'd like to acknowledge the PIs, supervisors, mentors, and the study team that have been working with the patients, HIV clinic staff, and also the Institute of Global Health at Northwestern University, which has provided me with space and time to work on this project. Thank you.
Thank you so much, Dr. Otaro, for that presentation. I'm just going to remind anyone that's in the room that if you have any questions, please type them in the Q&A box. But I will just kick things off with the question for you, Dr. Did you think that, given that you did note that you have an older population sample, and that might just be due to the fact that, there are several comorbidities which might be more prevalent in older populations, but I noticed, that when you shared the coping strategies that your participants shared with you, do you think that those might have varied if there were maybe a younger population sample included? I'm just thinking particularly about, being more risk averse across different generations. So I'm curious, especially given your clinical background, any thoughts you have on that?
Yes, thank you. That's a very good question. And actually, we looked at it. We tried to see if there's a difference in coping strategies depending on the age of the patient. We found out that we had the younger group relied more on lifestyle modification because they don't have time to go to the clinic, because they have to work, so they don't have time to attend the cardiovascular disease clinic care for. They don't have time to attend the hypertensive clinic or diabetes clinic. So this group focused on lifestyle modification, and it's this group that just goes to the pharmacy or dispensaries to buy medication when they feel like they really need to use the medication. But most of them say that they are not planning to use any medication. They are okay with lifestyle modification and they are okay with that. And then we had an older group which could not afford doing lifestyle modification because eating healthy is also expensive on this side, and they cannot afford to buy medication frequently. So this group focused on herbal treatment, the traditional herbal treatment, and it's a group we have some of the participants with already complications because of the use of the herbal treatment.
Okay, very interesting. So there were some differences that you noticed even in the study, which is, I guess, maybe something that we might expect at first intuitively, given generational differences, but nonetheless really interesting to see come forth in a study.
Mm.
And okay, no questions in the Q&A. And then I also was curious if you had experienced any, I think in the past it was more so the case that there was just this very unfortunate stigma attached to persons living with HIV. And I was curious if you encountered that at all as you were looking to recruit participants from the study, or if hopefully these days it's less of an issue.
If you recruit participants at the HIV clinic, then they are more comfortable when there is their safe space. So we did not have such an experience. If you recruit participants at the HIV clinic, the only issue that they raised that is related to stigma is that they were concerned if you are integrating care at the HIV clinic and then you start providing care for hypertension and diabetes, you'll have hypertensive individuals who are not living with HIV, and then they would want to come to the clinic because they will also receive care for their hypertension, and they did not want that. Yeah.
Thank you. I guess it's good to know that there is a set safe space, as you described, at the clinic, enough for them to feel comfortable to participate in the study and help increase the information from your research. All right. If there's no questions, then I'm just going to thank you once again for your presentation, Dr. Otaru. We are again going to have this recording available on the website, on the conference website, for the duration of a year from today. So it will be accessible for anyone in the future that wants to access it over that period. And thank you once again, Dr. Otaru. And then I'm just going to shift things to our next presentation and introduce Ms. Leah Goka. Please let me know if I'm mispronouncing that, Leah.
It's Goki. Close. Thank you.
Thank you, Leah Goki. All right, and Leah is joining us from Quantitative Engineering Design in Pittsburgh, in the USA, and her presentation title is How to Monitor Differentiated HIV Testing Services at National Scale, Digitizing Client Records from Routine Testing Registers Using ScanForm Technology in Malawi. And Leah is an epidemiologist with over 8 years of experience in global health, program implementation, and diplomacy. She previously worked in the Strategic Information Branch in the Division of Global HIV and TB for CDC Tanzania, focusing on surveillance and monitoring and evaluation activities. As a Peace Corps volunteer in Zambia, she worked with community health volunteers on sustainable agriculture practices and malnutrition workshops. She earned her BAs in biology and anthropology from Bucknell University and her master's in public health in epidemiology from the University of Pittsburgh. So with that, I will turn things over to you, Leah.
Great. Thank you so much, Dilshad. It's a pleasure to be here today with this audience and having this opportunity to present to you all today. Let me just get into full screen. Okay, hopefully you can see my title slide. Great, awesome. So yes, today I'd like to talk to you about a pilot that me and my team performed in Malawi. So this is all about Malawi's HIV testing services. First of all, there were some challenges that the Department of HIV and AIDS under the Ministry of Health of Malawi were facing. First, the need for timely, accurate, and finely disaggregated reports from HIV testing services, as well as the self-test distribution registers. In Malawi, there's thousands of service delivery points nationwide in the facility, and as well as the community. And next, another challenge is that there are extreme limitations in infrastructure here in Malawi. We have load shedding or electrical power outages at least 50 to 75% of the time, with intermittent network, as well as gaps in digital literacy. So DHA was experiencing challenges with their current routine registers and getting the transcription of paper-based records into digital data. So they sought out our services from QED and our technology, ScanForm, which is a sustainable solution for scalable data collection. This is a very simple workflow. This is exactly what we use in Malawi, which is actually where I'm calling you from today. Daily, healthcare providers or the HIV diagnostic assistants here in Malawi write on paper their regular routine registers, and then they take a picture with an Android smartphone. This ScanForm is able to automatically digitize handwriting from the snap of that picture and uploads it into and creates digital data. On a weekly basis, there are data quality reports that are compiled from these pictures of these pages of data. These reports are sent back to the facilities via the ScanForm app. So the HDAs can look at these data quality reports on the phone and go back and make any corrections that they might need to back on the register. You can see that correction in step 4. It's as simple as using a pen, shading out a box, and marking your correct answer, and then retaking the picture. This is performed on a weekly basis. So then by the end of the month, ScanForm is able to automatically generate Ministry of Health compliant summary reports, as well as PEPFAR disaggregated reports. All of these are cleaned because there's been the process of continuous quality improvement throughout that reporting month. So you can have confidence in your data quality. This is all able to be done without stable electricity, computers, scanners, or network required. So here's a quick summary of our pilot that occurred last year from March 2021 to March of 2022. There were 9 facilities shown on the map at the right that were included in the pilot, coming from all 3 regions in Malawi. And to ensure high accuracy from ScanForm, before this pilot began, we collected handwriting samples from over 1,000 healthcare workers to make sure ScanForm was calibrated to local Malawian handwriting. And we piloted 3 routine HTS registers that you might all be familiar with that you see in the facility. We piloted an initial register that captures the results from test 1 in the HTS testing algorithm, and then the confirmatory register, which captures test 2 and test 3 results, as well as perhaps syphilis testing, hepatitis testing, and recency testing. And then lastly, the self-test register, which is used to give clients tests to take home so that they themselves as a user or perhaps a contact can perform HIV self-testing. The results, which I will go into more detail in this presentation, but as I mentioned, these Ministry of Health registers, the initial, confirmatory, and self-test, now auto-calculate all summary statistics, saving at least 2 to 10 days working per month. In the prior process, this was a very manual and very labor-intensive process, where the HDA would not only have to write this data first on the register, but then perhaps again in a weekly summary sheet, and then for sure again at the end of the month for those monthly reporting deadlines. That all is automatically done now with the snap of a picture. And if the audience is familiar with PEPFAR and certain indicators such as HTS-TST, which is the number of tests, HIV tests that have been done, as well as HTS self, these are now auto-generated with the precise age, sex, and modality disaggregates that are required. So here is a screenshot, for example, from a health center that was piloted, Kawale. And you can see that every single element that is required for HIV testing services and program monitoring is completely auto-calculated without human errors with ScanForm. And now I'd like to just show you quickly what these registers look like. So you might be familiar with the basic elements on an HIV testing register. On the far left, you will see we have the access points, facility and community. We capture information about the kit name, kit lot number, expiry dates. All providers here in Malawi have a provider ID, so we're able to capture that information. We capture sex pregnancy with different disaggregates. We also capture prior HIV testing history and prior ARV use if applicable. And then the last column documents the HIV test 1 result. Here is the second page. There's hepatitis B screening and partner HIV status. There's a lot of information that we can collect. You might notice what I would like to draw your attention to with these registers is the variation between boxes and ovals. So boxes are used to capture either letters or numbers. So for example, at the top, you can see kit lot number. That can be a combination of letters or numbers. And then certain elements on this tool are ovals. For example, hepatitis B screening. Ovals are used to mark a selection. So in this case, hepatitis B screening, we expect one answer to be selected, either negative, positive, or not done. And that is simply indicated by crossing an X in that oval. So it's, paper is familiar. This process is still the same that HTA providers are used to, but this really simplifies the reporting process downstream. Next, if a client is confirmed positive, now this was a unique element that we improved upon. The majority of clients that are tested in Malawi are actually negative because of the significant progress that Malawi has made in gaining HIV epidemic control. For those clients that have a test 1 positive, their information is then captured in the confirmatory register. So you can see on the left, this is where the personal identifying information is captured. For negative tests, we are not interested in capturing that highly sensitive PII because there is no follow-up necessary for a negative test. This is most important for these clients that test positive. Anything outside of the dashed border that you see on this confirmatory register is automatically redacted. So while the facility captures this very important PII for their own follow-up done at the facility, it is never captured in the ScanForm image, nor is it uploaded into the data. So only everything within the dashed lines is digitized into data. And here you can see the additional test results are captured. There's a section for recency testing if applicable, and we can also capture referral outcomes as well, whether for ART or for retesting. And this is a screenshot of what the self-testing register looks like. I'll just go through it quickly. It's very straightforward. You have elements like the visit date, again, the provider ID, and then we capture basic information about the recipient and any HIV testing history, if that's appropriate. Additionally, we indicate if this is for self-use or it's self-tests can be distributed as many as 3 for other end users. Up to 3 additional end users are able to be tested with a self-testing register. Here are the results that I'd like to share. So these are the results from the benchmarking done with the 1,400 handwriting samples that we collected before the start of the pilot. As you can see, the first type of mark, the check boxes, which are done in the ovals, this was met at 100% certainty. The digits or the numbers were also very high, over 99%, and the letters were over 98%. So these accuracy stats that we observed in Malawi, which are highly accurate and exceeding the performance in other countries. Another result that I had mentioned in the workflow is that with ScanForm, there's the ability for fully automated data quality assessments performed because a picture of each page of data is collected, and we know exactly how many elements that we expect and the types of answers that are valid or invalid This is all able to be done automatically. So this result is that we can monitor accuracy, completeness, missing pages, and timeliness in real time. And this results in a massive reduction of monitoring and evaluation costs through remote supervision. And all of these summaries are pushed directly back to the ScanForm phone at the facility. So that way the providers can perform continuous quality improvement during that reporting month, as opposed to further down, months later, even, a year later, perhaps, when ad hoc data quality assessments are normally performed. This is a screenshot of the ScanForm app showing how missing pages are tracked. So because each page in a ScanForm register is uniquely marked with QR codes and data matrices, we are able to know exactly how many pages should be uploaded. For example, some provider might accidentally upload page 1 and then page 3. ScanForm knows to send the notification that you need to go and please take a picture of page 2. Another powerful feature of ScanForm was the ability for imputation, which is any missing data. So in this first example, ScanForm can impute a default value. In this example, you can see that referral slips given was marked as a 1 and 20 male condoms were given, but female condoms were left blank. And working with the DHA, we designed a rule so that way if female condoms were left blank, this should just be imputed as a 0 to improve completeness of the data. Another way that imputation can be worked is by a default option. So for example, if sex or pregnancy status was not marked, we would fill in female not pregnant when that is missing. And lastly, another process that was done was called fuzzy matching, or the imputation of the correct provider ID if a character is wrong. Sometimes a provider might accidentally mess up a digit or a letter. For example, 45E5 was written, but we know from the master list of provider IDs that this should actually be 45EJ. So as a result of imputation, the completeness is automatically improved without additional time or effort required at the facility level. Here is the blue bars are showing the raw data before imputation, and then the red bars are showing the clean data after imputation. And this is the performance from all 9 facilities in the pilot, which showed an improvement. Here is the results of timeliness during this pilot. Overall, over 77% of the entries were submitted on time, and all records were submitted on time in June. During the month of December of 2021, just wanted to note, the holidays, typically reports are submitted late, and additionally in Malawi, the Omicron variant was detected, which also impacted the timeliness of the reports submitted. Another element of our pilot was that it was externally evaluated by a third-party group with focus groups, and the results were very, very positive. All 100% of the providers stated that data collection and reporting is faster with ScanForm. And these bullets are some direct quotes from those focus groups. Lessening my time for doing my monthly reports. There is no longer a burden of report writing because this is automatically generated now. And overall, providers found that the ScanForm was very simple and very easy to use without challenges. So lastly, like I said, I'm calling you today from Malawi. We have secured funding for the national scale-up of all 3 of these HTS registers to over 700 facilities and across over 4,000 providers, thanks to resources from Global Fund. As I said, there is access of all of this data on this, via the smartphones in the clinic, so on-site as well as off-site with a dedicated web portal. This is also a very, very powerful monitoring and evaluation tool because fully remote audits can be performed. And there are plans underway to expand ScanForm to other services such as HIV viral load request forms, EID, exposed infant diagnosis, and STI, sexually transmitted infections, and to interoperate with other systems here in Malawi, like the Lab Information Management System and even the point of care EMR. So I would like to give a special thanks to the Ministry of Health here in Malawi, as well as Global Fund and the World Health Organizations for their funding and support. If you are interested in ScanForm, perhaps you're using paper for your data collection, we would be happy to hear from you. Please reach out to us at scanform@qed.ai. And here are some other resources as well. You can please check out our website at qed.ai for more information. We would be happy to hear from you and to see how we can work together to strengthen data systems together. Thank you.
Thank you so much, Leah. I appreciate that. Thank you for your presentation. I'm just going to remind anyone that's on the call to please enter any questions you might have into the Q&A so that I can share them with our presenter and pose those questions to her directly. I'll just kick things off if that's all right. You did mention, and it's pretty, intuitive, that there is the ScanForm provides a workaround, especially for dealing with load shedding when it's very difficult to really enter anything online or just get online. So I'm curious on the opposite end of things. So once the information and data has been uploaded, do service providers then become captive, if you will, again, to load shedding when it comes to accessing this information if it's all online?
Right. Thank you for the question. No, because we're actually able to push things. We are able to configure these phones with something called mobile device management. So QED is able to make sure that these phones are only used for ScanForm related purposes, uploading the data, and any updates to the app we control and make sure that is pushed so all users are using the most up-to-date apps. But by the 5th of the following month, all of these reports will be pushed to the phones. So perhaps maybe if there happened to be a 24-hour day of no load shedding, then maybe that is a challenge that somebody might not be able to access. But since it's pushed at a time when there is internet connectivity, once it's there and available, even without internet access.
I see. And are they ever available maybe offline as well, or is it purely just online, the records?
Yes, definitely offline as well.
Got it. Okay. No, that's great.
I hope I'm explaining that clearly. Yes.
Yeah. No, thank you. That was clear. And then I was curious, just in terms of getting the participants and the service providers on board with this new type of, well, I would assume for them or really anyone, a new type of data capturing. Was there a general willingness or unwillingness to learn a new technology? And if there was, either way, how you dealt with that?
Certainly. Yeah. Thank you for the question. One of the advantages with ScanForm is its scalability and simplicity. Most of us know how to document information on paper. So that was received very positively from the healthcare providers. It wasn't as complicated as learning a new tablet or perhaps a point of care computer system. Yes, there is an adjustment to writing one letter or one number per box. That is an adjustment to how you normally are writing your information, but the advantages of what, kind of changing your initial entry, it was very well received. Mobile devices have penetrated deeply, in sub-Saharan Africa, despite these limitations in infrastructure. People know how to take pictures. During the training, we covered these sessions just to make sure that the providers feel comfortable. They practice writing, in the tool in advance, practice taking the pictures. The app has corner guides in each corner to help assist the user to make sure, just get the corners of each page in these little green boxes, snap the picture, and it's really as easy as that. If you're connected to internet, the upload and processing of that information can be as quickly as 30 to 45 seconds if you're connected to stable internet so you can have hands. So I would say that it was just very well received. Of course, there wasn't a little adjustment initially just to that difference of the writing, but people did overall report that it was just faster reporting, marking selections as opposed to writing things out, and widely accepted in the country.
Thank you for that. Yeah, so it sounds like you did offer the training just to get the familiarity going for the users, and then I guess the technology that was used, the basics of the technology were pretty familiar as far as, taking pictures on mobile phones goes. So
Yes,
thank you for
yes.
that.
Thank you. Yeah, thank you for the questions. It was, we'd like to say that we're replacing manual data entry, manual writing on perhaps a monthly report and trying to auto calculate, and humans make errors from all of that transcription. The PEPFAR monthly reports alone require 800 data elements to be submitted with these age, sex, modality, dissags per facility. All these providers are already doing so much work with providing the highest quality of care that they can to their patients. We're just here to eliminate that burden so they can focus on their service delivery and just eliminate that manual data entry process with just the picture instead.
That's excellent. Thank you. And then we do have a question in the Q&A box, so I'll just read that off for you, Leah. The person is asking, how did the providers perceive the intervention? Well, I think you answered this a little bit, but maybe you can elaborate. How did the the providers perceive the intervention in terms of workload? They will have to fill in the routine forms and then scan forms. So maybe, I guess, how did that workload compare to their previous one, and how did they just perceive it?
Sure, thank you. So the short answer is that it's not a duplicative process. We make the routine forms scannable. So the now official Ministry of Health registers are compatible with ScanForm. They don't have to do it twice, not in the perhaps the older tool and now the ScanForm tool. It's all, we make the routine forms now scannable. The design, as you saw, the major differences from what the previous routine register looked like. We had added the dashed lines around the borders for the automatic redaction of any sensitive PII. And then we add the QR codes and the data matrices just so we're able to uniquely identify every single page. And that allows us to perform the data quality assessments and monitor the completeness. So the intervention did not double their workload in terms of writing twice. It actually is, it's still, with ScanForm, you write on paper once and only once, and you get digital data with the snap of a smartphone picture.
Okay, thank you. Thank you for that. I mean, I think that makes sense. Yeah, it sounds like it further explains why it would have been a generally well-received type of intervention or modification, if you will. All right, if there aren't any more questions, I'm just going to thank both of our presenters, Dr. Otaru, as well as Ms. Leah Goki, for their presentations and for joining us for the SUC-UGH conference this weekend. We very much appreciate it. And with that, I will just remind everyone, if you have applied for CPD points, the information on obtaining those points and details will be shared or is up on the website, so you can access it there. And then you'll also receive an evaluation for the session and for today's group of sessions. So please do be sure to complete that evaluation. And thank you, Leah, for including your email. Leah just included her email there in the Q&A box for anyone who wants to communicate with her. And thank you once again, Dr. Otaru and Leah Goki.
Thank you for the opportunity.